Welcome to this video entitled, Acute Stroke. Regarding acute stroke, stroke should be suspected whenever a patient presents with the characteristic sudden onset of focal neurologic signs such as hemiparesis, hemisensory loss, hemanopia, aphasia, or ataxia, as shown in Table 6.1. Time is of the essence for treating stroke because reperfusion therapy always works better when given as early as possible. It has been estimated that every 15-minute reduction in onset to treatment time translates into a meaningful reduction in the risk of long-term disability at 3 months. Because of the importance of early intervention in acute stroke, the emphasis of emergency room (ER) management should not be on identifying subtle, unusual, or interesting neurologic signs but on the following 5 priorities. When a stroke code is called, tasks are ideally performed in parallel by 4 different personnel immediately on patient arrival, e.g., the emergency department attending, resident, nurse, and stroke neurologist. 1. Assess level of consciousness and ensure adequate airway, breathing, and circulation. 2. Obtain the history with precise attention to the specific time of onset, or discovery, of symptoms, along with a list of current medications. 3. Establish large bore, preferably 18-gauge, intravenous access, and obtain admission labs. 4. Perform a National Institutes of Health Stroke Scale, abbreviated as NIHSS, examination. 5. Obtain head non-contrast computed tomography, abbreviated as NCCT, and CT angiogram imaging as soon as possible. It should be kept in mind that mortality is reduced and the likelihood of a good recovery is increased when stroke patients are cared for in a dedicated stroke unit. If your patient is unusually complex or critically ill, consideration should be given to transferring the patient to the nearest comprehensive stroke center once he or she has been stabilized. This chapter focuses on the emergency management of stroke. Additional information regarding hospital care and long-term management can be found in Chapter 24. We will now take a closer look at Table 6.1 summarizing presentations of acute stroke. It is characterized by the following. 1. Abrupt onset of facial or limb weakness, usually hemiparesis. 2. Sensory loss in one or more extremities. 3. Sudden change in mental status, manifesting as confusion, delirium, lethargy, stupor, or coma. 4. Aphasia, manifesting as incoherent speech, lack of speech output, or difficulty understanding speech. 5. Dysarthria, manifesting as slurred speech. 6. Loss of vision, which may be hemanopic or monocular, or diplopia. 7. Ataxia, truncal or limb. 8. Vertigo, nausea and vomiting, or headache. Regarding the phone call, questions to ask include the following. 1. What were the presenting symptoms? 2. Exactly when did the symptoms begin? If the symptoms were unwitnessed, what was the time last known well and time of discovery? 3. Have the symptoms worsened, fluctuated, or improved since onset? 4. What are the vital signs? 5. Does the patient have a history of hypertension, diabetes, or cardiac disease? 6. Is the patient taking any antiplatelet agents or anticoagulants? It is particularly important to perform an urgent CT scan on patients taking anticoagulants to rule out intracerebral hemorrhage, abbreviated as IC, because early treatment reversal agents can be life-saving. Orders should include the following. 1. Establish an IV line with 0.9% normal saline at 1 ml per kilogram per hour. Hypertonic fluids such as D5W and half normal saline aggravate cerebral edema. 2. Place a pulse oximeter and apply oxygen if there is respiratory distress or if the oxygen saturation is less than 95%. 3. Make sure the patient gets nothing by mouth. Is made NPO. 4. Place a portable cardiac monitor. 5. Order a stat non-contrast head CT scan and ACT angiogram, as shown in Box 6.1 and Fig. 6.1. 6. Order and draw the following diagnostic blood tests, but do not delay imaging or treatment waiting for lab test results. A. Complete blood count, CBC, and platelet count. B. Serum chemistries, glucose, electrolytes, blood urea nitrogen, BUN, and creatinine. C. Prothrombin time, PT, international normalized ratio, INR, partial thromboplastin time, PTT. D. Cardiac troponin level. We will now focus on Box 6.1 discussing emergency computed tomography, angiography and perfusion imaging for acute stroke. Increasingly, major stroke centers are routinely incorporating computed tomography angiography, abbreviated as CTA, into their acute stroke algorithms with the goal of detecting a treatable large vessel occlusion. See Figure 6.1. Early detection of large vessel occlusion is crucial because this is the trigger for proceeding with mechanical thrombectomy. Stroke centers are increasingly using a computed tomography angiography for all policy, in which a computed tomography angiography is performed at the same time as the initial non-contrast CT for all stroke codes within 24 hours of last known well, regardless of the baseline national Institutes of Health stroke scale score, abbreviated as NIHSS score. When a large vessel occlusion is detected, but the patient is presenting between 6 and 24 hours from last known well, computed tomography imaging is then performed to help identify good candidates for thrombectomy. Automated image analysis software calculates the volume, in milliliters, of core infarction, that is a cerebral blood flow less than 30% of normal, ischemic penumbra, mismatch volume, T marks greater than 6 seconds, and mismatch ratio, that is mismatch to core volume. In these protocols, routine documentation of a normal serum creatinine level is waived because of the urgency of the situation and the low risk of serious contrast-induced nephropathy, less than 1%. Demonstration of a treatable large vessel occlusion then triggers an interventional, secondary page, that mobilizes the interventional team with the goal of beating a 60-minute, picture-to-puncture, time interval. We will now look at some elevator thoughts. What are the causes of stroke? 1. Infarction causes 80% of all strokes. A. Regarding embolic type, there can be a 1. Cardiogenic embolism due to the following: A. Atrial fibrillation or other arrhythmia. B. Left ventricular mural thrombus. C. Mitral or aortic valve disease. And D. Endocarditis, infectious or non-infectious. 2. Embolic stroke of unknown source, abbreviated as ESUS. 3. Paradoxical embolism, involving the patent foramen ovale. 4. Aortic arch embolism. B. Regarding the atherothrombotic type, due to large vessel or medium vessel disease. It can be 1. Extracranial disease, which may be A. Internal carotid artery, abbreviated as ECA. B. Vertebral artery. 2. Intracranial disease, which may involve the following: A. Internal carotid artery. B. Middle cerebral artery, abbreviated as MCA. C. Basilar artery. D. Lacunar, small penetrating artery occlusion, other or unknown. 2. Intracerebral hemorrhage, abbreviated as IC, causes 15% of all strokes. They may be due to A. Hypertensive causes, B. Amyloid angiopathy, or C. Arteriovenous malformation, abbreviated as AVM. 3. Subarachnoid hemorrhage, abbreviated as SAH, causes 5% of all strokes, which can be A. Aneurysmal, accounting for 80%, and B. Non-aneurysmal, accounting for 20%. 4. Miscellaneous causes can lead to infarction or hemorrhage. Examples include the following: A. Dural sinus thrombosis, B. Carotid or vertebral artery dissection, C. Central nervous system, CNS, vasculitis, D. Moyamoya disease, progressive intracranial large artery occlusion, E. Migraine, F. Hypercoagulable state, G. Drug abuse, cocaine or other sympathomimetics, H. Hematologic disorders, sickle cell anemia, polycythemia, or leukemia, I. Mitochondrial encephalopathy, lactic acidosis, and stroke, abbreviated as MELAS, and J. Atrial myxoma. Pause the video and carefully scrutinize Figure 6.1 illustrating a computed tomographic angiogram demonstrating occlusion of the M1 segment of the left middle cerebral artery as shown by the blue arrow before advancing to the next slide. Stroke is a major threat to life. A. LTS begin with transtentorial herniation. It occurs primarily in the following presentations. 1. Massive hemispheric infarction or hemorrhage. 2. Intraventricular extension of intracerebral hemorrhage or subarachnoid hemorrhage. B. Cerebellar infarction or hemorrhage. All patients with large cerebellar lesions require neurosurgical evaluation because emergent decompression can be life-saving. C. Regarding aspiration. Aspiration pneumonia is a common cause of death in stroke patients. All patients should be considered to have impaired swallowing until proven otherwise. D. Regarding myocardial infarction. Acute myocardial infarction complicates approximately 3% of acute ischemic strokes. At the bedside do the following. 1. Quick look test. What is the patient's level of consciousness? The urgency of the situation can be assessed immediately by evaluating the level of consciousness. Patients in stupor or coma are at the highest risk for further deterioration, and are most likely to benefit from urgent intervention. 2. Airway and vital signs. A. Is the patient in respiratory distress? If the patient's breathing appears labored, check arterial blood gas levels and start oxygen. Patients with severe dyspnea or depressed level of consciousness, manifesting as stupor or coma, should be intubated prior to CT scanning. Failure to control the airway in either setting can lead to massive aspiration or to respiratory arrest. B. What is the blood pressure, BP? Hypertension occurs frequently after stroke as a nonspecific response to cerebral injury. In ischemic stroke, this response may be advantageous because increased cerebral perfusion pressure improves blood flow in regions of marginally perfused brain, the ischemic penumbra, that have lost the capacity to autoregulate. As a result, overly aggressive blood pressure reduction in acute ischemic stroke patients can lead to worsened ischemia and neurologic deterioration. For this reason, Only severe hypertension should be treated prior to CT scanning, unless there is a non-neurologic indication, as summarized in Box 6.2. If the patient meets one of the criteria listed in Box 6.1 and needs urgent blood pressure control, start with IV nicardipine 5 mg per hour, that is 1 mg per 10 ml, and adjust the rate to attain the desired blood pressure target, see Box 6.1, up to a maximum of 15 mg per hour. If a second agent is needed to control blood pressure, or if rate control is required to maintain heart rate less than 100 beats per minute, push 20 mg of IV labetalol over 2 minutes, then repeat 40, 60, and finally 80 mg at 10-minute intervals until the desired blood pressure is attained, up to a total dose of 200 mg. Low blood pressure in acute stroke is unusual. Hypotension that is severe enough to precipitate cerebral infarction is rare, but can occur in patients with severe carotid artery or intracranial artery stenosis. See what is the heart rate. Rapid atrial fibrillation is frequent in acute ischemic stroke and may require treatment with IV labetalol as previously mentioned. Alternatives include diltiazem 20 to 25 mg or verapamil 5 to 15 mg. IV push. D. What is the temperature? The most common cause of fever at onset after stroke is aspiration pneumonia. If fever is present, give acetaminophen 650 mg by mouth, and order a cooling blanket and blood and urine cultures. If respiratory distress is present or the patient looks especially sick, consider administering antibiotics empirically. Amoxicillin, sulbactam, marketed as Unicin, dosed at 1.5 grams IV every 6 hours, or clindamycin 600 mg IV every 8 hours. Next we will focus on Box 6.2 summarizing guidelines for emergency department treatment of hypertension in acute stroke. Prior to computed tomography scanning, treat hypertension if a non-neurologic hypertensive emergency exists, e.g. in the following scenarios. 1. Acute myocardial ischemia. 2. Cardiogenic pulmonary edema. 3. Malignant hypertension, retinopathy. 4. Hypertensive nephropathy or encephalopathy. 5. Aortic dissection. Also treat hypertension if the blood pressure is highly elevated, that is, 1. Systolic blood pressure of greater than 220 mm of mercury. 2. Diastolic blood pressure of greater than 120 mm of mercury. Otherwise, systolic blood pressures of 160 to 220 mm of mercury should not be treated prior to CT scanning. After computed tomography scanning, 1. If intracerebral hemorrhage is identified, reduce the systolic blood pressure to 140 to 160 mm of mercury. 2. If the decision is made to give tissue plasminogen activator, abbreviated as TPA, reduce systolic blood pressure equal to or less than 180 mm of mercury and diastolic blood pressure equal to or less than 105 mm of mercury. Next we will look at selective history. If possible, obtain an eyewitness to corroborate the patient's account. Be sure to check the following. 1. Exactly what time did the stroke begin? If the symptoms began within 6 hours and an ischemic stroke is confirmed by CT, IV or intra-arterial reperfusion therapy may be possible, and the evaluation should proceed as quickly as possible. 2. What were the initial symptoms? A maximal deficit at onset in a fully alert patient supports cerebral infarction and suggests embolism in particular. Loss of consciousness, headache, or vomiting supports intracerebral hemorrhage. Inquire specifically about the following: a headache or neck pain, hemorrhage or dissection. B. Loss of consciousness. C. Confused or slurred speech. D. Visual disturbances. E. Dizziness or vertigo, brainstem ischemia. F. Weakness or clumsiness. G. Numbness or paresthesias. H. Gait instability. 3. Were there any antecedent attacks consistent with transient ischemic attack, abbreviated as TIA? 4. Was any seizure activity observed? 5. What is the patient's medical history? 6. Has the patient used drugs or alcohol recently? Cocaine can precipitate infarction or hemorrhage. 7. What medications is the patient taking? We will now look at selective physical examination. We will begin with general physical examination. Regarding the neck, auscultate for carotid bruits. Neck stiffness suggests subarachnoid hemorrhage. Regarding the lungs, check for aspiration pneumonia or congestive heart failure. Regarding the heart, murmurs suggest valvular heart disease and a possible source of embolism. Next we will consider neurologic examination. Because time is of the essence, the initial neurologic examination needs to be systematic and efficient. The goal is to simply localize and characterize the severity of the deficit. An experienced examiner can accomplish this in 10 minutes. A more detailed examination should be performed later. Focusing your examination on these elements will allow you to calculate an NIH stroke scale score. See www.mdcalc.com/knee-stroke-scale-score-nice. We will begin with mental status. Pay attention to the following. 1. Level of consciousness and attentiveness. 2. Orientation. Ask the patient what month it is and how old they are. 3. Regarding aphasia, check the fluency of spontaneous speech, naming, repetition, and paraphasic errors, that is word or syllable substitutions. Ask the patient to open and close his or her eyes and grip and release his or her strong hand. Then ask the patient to read some simple sentences and name objects, shown in Figure 6.2. 4. Hemispatial neglect. Forced head and gaze deviation implies a large hemispheric lesion. Next we will look at the cranial nerves. 1. Regarding visual fields, ask the patient to count fingers in all 4 quadrants. Check the patient's blink to threat if the patient is inattentive. 2. Regarding the pupils, asymmetry suggests brainstem ischemia. 3. Regarding extraocular movements, check horizontal eye movements, looking for a conjugate gaze paresis. 4. Regarding the face, a widened palpebral fissure and flattened nasolabial fold are indicative of facial weakness. 5. Regarding the palate and tongue, check for symmetry and adequacy of the gag reflex. Next we will consider motor function. 1. Regarding spontaneous movements, preferential movement of the limbs on one side indicates paresis of the unused limbs. If the patient is unresponsive, check for a preferential localizing response to sternal rub. 2. Regarding limb tone, increased tone occurs with deep lesions in the internal capsule or brainstem. 3. Regarding arm, pronator, and leg drift, if the patient is unable to follow commands, then passively elevate the arms and legs and check whether one falls preferentially. 4. Regarding power, check strength against active resistance at the shoulders, wrists, hips, and ankles. We will now focus on reflexes. There may be 1. Deep tendon reflexes, or 2. Plantar reflexes. Proceed with the following elements of the neurologic examination only if the patient's level of consciousness allows. A. Sensory. 1. Pinprick or pinch test identifies a lateralized deficit. B. Coordination. 1. Finger-to-nose test identifies intention tremor and past pointing. 2. Gait and station. Check for reduced arm swing on the paretic side. A wide base is indicative of truncal ataxia. Pause the video and carefully scrutinize Figure 6.2 illustrating the images used to test for aphasia, containing objects to name and sentences to read before advancing to the next slide. Pause the video and carefully scrutinize Figure 6.2 illustrating a picture to describe before advancing to the next slide. We will now progress to the management. We will begin with acute management. Once the history and examination are completed, you should be able to localize the lesion clinically. The main differential diagnoses are infarction and hemorrhage, which can be accurately diagnosed only by CT or magnetic resonance, MR. Hence, all further management decisions, thrombolysis, blood pressure management, or further workup, will depend on the results of brain imaging. We will now take a closer look at hemorrhage. Let's begin with its radiographic assessment. Blood is readily identified by the presence of a high-density, bright signal, as shown in Figure 6.3. If intracerebral hemorrhage is present, be sure to check for the following radiographic findings. 1. Subarachnoid hemorrhage, see Fig. 6.3b, in association with intraparenchymal hemorrhage suggests a ruptured aneurysm and requires angiography. 2. Intraventricular hemorrhage, see Fig. 6.3c, in association with ventricular enlargement requires neurosurgical evaluation for possible emergent ventriculostomy. 3. Fluid levels within a hematoma, as shown in Figure 6.3d, result from separation of red blood cells and plasma and are indicative of a coagulopathy. 4. Edema and mass effect usually lead to delayed neurologic deterioration when associated with a large hemorrhage, more than 30 milliliters. An abnormally large or an irregular amount of edema associated with hemorrhage suggests 1. Hemorrhagic infarction. 2. Bleeding associated with neoplasm. Or 3. Venous infarction from dural sinus thrombosis. Pause the video and carefully scrutinize Figure 6.3 illustrating computed tomography scans of brain hemorrhage before advancing to the next slide. We will now look at a checklist for acute management of intracerebral hemorrhage. 1. Rule out coagulopathy. Confirm that the prothrombin time, INR, and partial thromboplastin time are normal. If the prothrombin time is elevated or the patient is actively taking warfarin or another form of oral vitamin K antagonist anticoagulant therapy, give a 4-factor prothrombin complex concentrate, abbreviated as 4-FPCC, Kcentra, CSL Behring, King of Prussia, Pennsylvania, 25 units per kilogram or 50 units per kilogram IV push. Give the higher dose if the INR is above 6. Then give vitamin K 10 mg by IV push, and repeat as needed daily for the next 3 days until the INR is normalized to below 1.4. To reverse unfractionated or low molecular weight heparin, abbreviated as LMWH, give protamine sulfate 10 to 50 mg by slow IV push. 1 mg reverses approximately 100 units of heparin or low molecular weight heparin. Give enough to reverse all of the heparin received within the last 2 hours. Reverse dabigatran or other direct thrombin inhibitors with idarucizumab, marketed as Praxbind, 5 grams IV. Reverse factor Xa inhibitors, such as edoxaban, rivaroxaban, and apixaban, with Andexa net alpha, marketed as Andexa. The low-dose regimen is 400 mg as a bolus followed by 4 mg per minute for 120 minutes. The high-dose regime is 800 mg as a bolus followed by 8 mg per minute for 120 minutes. Give the high dose if the patient last took more than 10 mg of rivaroxaban, or more than 5 mg of apixaban, within the last 8 hours. Note that platelet transfusion is not recommended for intracerebral hemorrhage patients on antiplatelet agents, such as aspirin or clopidogrel, based on a clinical trial suggesting that platelet transfusion worsens outcome. It remains reasonable to give platelets for reversing thrombocytopenia, or for patients on antiplatelet therapy who are about to undergo a neurosurgical procedure. 2. Control severe hypertension. In contrast to the approach taken with acute cerebral infarction, a somewhat more aggressive approach to blood pressure control is suggested for patients with acute intracerebral hemorrhage because high levels may lead to worsening of perilesional edema. Although the optimal management has yet to be established, we advocate reduction of systolic blood pressure to a target between 140 and 160 mm of mercury using a labetalol or nicardipine infusion. See the section Airway and Vital Signs. 3. Consider emergent hematoma evacuation. The criteria for emergent evacuation of intracerebral hemorrhage are controversial. It is generally accepted that cerebellar hemorrhages greater than 3 cm in diameter should be evacuated when there is a depressed level of consciousness with clinical signs and radiographic evidence of posterior fossa mass effect. A randomized controlled trial found no benefit when craniotomy was performed for supratentorial intracerebral hemorrhage within 72 hours of onset compared with best medical therapy. Despite this, patients classically considered good candidates for emergency surgery, such as younger patients with early deterioration caused by symptomatic mass effect from a large lobar hemorrhage, were excluded from the trial, and in selected cases these patients might still benefit from surgery. Consideration should also be given to inserting a ventricular drain in stuporous or comatose patients with intraventricular hemorrhage and obstructive hydrocephalus, or a parenchymal intracranial pressure, abbreviated as ICP, monitor in patients with large, deep hemorrhages who are not candidates for surgery. 4. Consider angiography. Angiography can rule out an aneurysm or AVM. This is particularly important when subarachnoid hemorrhage is present, in young non-hypertensive patients when a lobar hemorrhage is present, or in any patient with a primary intraventricular hemorrhage. Angiography is almost always negative in chronically hypertensive patients with a hemorrhage in a classic hypertensive location, putamen, thalamus, pons, or cerebellum. 5. Osmotherapy. Consider mannitol, 1 to 1.5 grams per kilogram IV, for deepening coma or if clinical signs of brain stem compression are evident. See Chapter 13 for further details. An alternative is 0.5 to 2 ml per kilogram of 23.4% hypertonic saline if the patient is relatively hypotensive or hypovolemic. Steroids such as dexamethasone have not been shown to be effective in patients with intracerebral hemorrhage and should not be used. 6. Anticonvulsant therapy. Seizures at onset are unusual, but if present should be treated with phenytoin or fosphenytoin 10 to 20 mg per kilogram IV or levetiracetam 500 to 2000 mg twice daily. Prophylactic treatment with phenytoin or a similar anticonvulsant for 7 days is an option in patients whose condition is critical enough to require intubation, treatment for increased intracranial pressure, or surgery. Additional guidelines for the management of intracerebral hemorrhage or subarachnoid hemorrhage are included in Chapter 24 and in the section Management 2. General care in this chapter. Pause the video and carefully scrutinize Figure 6.4 illustrating early cerebral infarction, with loss of gray-white definition and sulcal effacement before advancing to the next slide. Pause the video and carefully scrutinize Figure 6.5 illustrating the Alberta Stroke Program Early CT Scale, abbreviated as Aspects, score before advancing to the next slide. We will now progress to infarction. Let's begin with radiographic assessment. 1. Non-contrast head CT. Infarction appears as a lucent, that is dark, signal on a CT scan, but may not be apparent until 12 to 24 hours after onset. Early signs of infarction, as shown in Figure 6.4, are important to recognize and include 1. Loss of definition of the gray-white junction. 2. Mild sulcal effacement. And 3. Subtle, hazy lucency. The extent of early infarction can be quantified with the Alberta Stroke Program Early CT Scale score, with 10 indicating no early infarction and 0 representing complete infarction of the entire MCA territory, as shown in Figure 6.5. 2. CT angiography, abbreviated as CTA, and CT perfusion, abbreviated as CTP. At many stroke centers, contrast-enhanced CT angiography and CT perfusion are increasingly being used as adjuncts to standard NC-CT imaging in the emergency department. Demonstration of a large vessel occlusion, abbreviated as LVO, see Figure 6.1, can be used to identify candidates for emergent angiography and mechanical thrombectomy, MT. See next for further discussion. 3. Magnetic resonance imaging, abbreviated as MRI. Diffusion-weighted imaging, abbreviated as DWI, reveals acute ischemic changes within minutes to hours of onset, which is long before infarction is present on CT or MR fluid attenuation inversion recovery, abbreviated as FLAIR, images. Accordingly, magnetic resonance imaging with diffusion-weighted imaging is probably the imaging modality of choice for patients with acute stroke. Gadolinium-enhanced perfusion-weighted imaging can also be used to identify regions of perfusion-diffusion mismatch, much in the way that CT perfusion is used. However, logistical problems often limit the timely performance of MR, which can delay therapy. Magnetic resonance imaging is most often used to assess the final extent of injury once all therapeutic intervention during the acute phase has been completed. Next we will discuss the goals of management. 1. Give thrombolytic therapy with IV tissue plasminogen activator, abbreviated as TPA. If possible, IV thrombolysis with tissue plasminogen activator within 4.5 hours of symptom onset is the only currently approved medical treatment for reversing ischemia in acute stroke. For eligible patients, 0.9 mg per kilogram of IV tissue plasminogen activator is administered up to a maximum dose of 90 mg, with the initial 10% given as an IV push and the remainder infused over 1 hour. IV tissue plasminogen activator only rarely results in immediate early neurologic improvement. Rather, it increases the chances of a good recovery at 3 months from approximately 30% to 40%. When given between 3 and 4.5 hours after symptom onset, the benefit of tissue plasminogen activator is less than when given within 3 hours, but it still improves outcome. However, in this time frame, patients must be 80 years old, have an NIHSS score less than 25, and not have a history of both stroke and diabetes mellitus. Note that blood pressure must be controlled to greater than 180 systolic, 105 diastolic prior to giving tissue plasminogen activator, and for at least 24 hours thereafter to minimize the risk of hemorrhagic conversion. Hyperglycemia is also an important risk factor for hemorrhage after IV tissue plasminogen activator and should be controlled with a regular human insulin infusion of 0.5 to 4 units per hour to maintain the serum glucose to below 180 mg per deciliter for the first 24 hours. Tissue plasminogen activator carries a 6% risk of symptomatic intracranial bleeding and should not be given if the head CT scan shows subtle early infarction signs involving more than 1/3 of the MCA territory, as evidenced by an aspect score of less than 7. Because the risk of hemorrhage increases significantly after 4.5 hours, this time window must be strictly obeyed. Table 6.2 shows a list of potential contraindications to giving tissue plasminogen activator within the 4.5-hour time window, and the strength of these contraindications according to the published literature. 2. Evaluate for the presence of large vessel occlusion and perform mechanical thrombectomy if possible. An important limitation of tissue plasminogen activator is that it fails to recanalize the occluded vessel in 40% of cases. When larger clots occlude the major large intracranial vessels, the proximal MCA, ICA terminus, or basilar artery, recanalization rates are even worse and outcomes remain poor, despite IV tissue plasminogen activator administration. Interventional bridging therapy is the strategy of proceeding immediately to endovascular intervention while tissue plasminogen activator is infusing. If a persistent large vessel occlusion is detected, then angiography, as shown in Figure 6.6, and endovascular intervention to extract the clot from the vessel using a suction or retrievable stent reaver device can then be attempted. See Chapter 24 for details. In 2015, 5 major randomized trials demonstrated that patients presenting within 6 hours of onset or last known well with large vessel occlusion documented by CT angiography benefited substantially from mechanical thrombectomy. Although there was no consistent reduction in mortality, the ability of the procedure to reduce disability is substantial, with a number needed to treat of 2.6 to reduce disability per patient. The treatment effect is not affected by age above 80 years or whether or not the patient receives tissue plasminogen activator. In 2017, 2 additional studies found that the benefit of mechanical thrombectomy can be extended to patients presenting within the 6 to 24-hour window from last known well if CT perfusion imaging showed a relatively large penumbra associated with disproportionately small core infarction. As a general rule, CT perfusion should show a ratio of penumbra to core of 1.8 and a core infarction no larger than 70 milliliters. As would be expected, patients who meet imaging criteria for thrombectomy in the extended time window tend to have severe deficits, median NIHSS 16, associated with higher aspect scores, generally above 6, indicating a small burden of early infarction. About half of eligible patients treatable in the 6 to 24-hour time window are wake-up strokes, and the others tend to have robust collateral, which extends survival of penumbral tissue. The approximate benefit is an increase in the percentage of patients with minimal deficit at 3 months from 15% to 45%, corresponding to a number needed to treat of about 3. Stroke is a team sport. To be successful, rapid evaluation and mobilization of the interventional team requires preparation and interdisciplinary teamwork. Stroke imaging protocols that include CT angiography and CT perfusion as first-line imaging, without the need for creatinine testing, has been shown to improve large vessel occlusion detection, increase the mechanical thrombectomy treatment population, hasten intervention, and improve outcomes after large vessel occlusion. The outcome benefit primarily affects patients presenting within 6 hours of symptom onset. Pause the video and carefully scrutinize Figure 6.6 illustrating angiogram, antero-posterior view, demonstrating total occlusion of the right M1 middle cerebral artery segment, corresponding to Part A, prior to intraarterial thrombolysis, and complete recanalization, corresponding to Part B, after the procedure before advancing to the next slide. Pause the video and carefully scrutinize Table 6.2 summarizing strength of evidence for contraindications to tissue plasminogen activator therapy before advancing to the next slide. 3. Identify the affected vascular territory to determine the mechanism of stroke. Identification of the affected vascular territory can provide important information regarding the mechanism of the infarction. The topography of the major arterial territories of the brain is shown in Figure 6.7. Examples of the 3 main patterns of infarction, described next, are shown in Figure 6.8. A. Territorial infarction respects the margins of an entire vascular territory or one of its branches. The cause is usually embolism, with infarction occurring in brain regions immediately distal to the site of occlusion. B. Border zone infarction may occur either 1. Along the boundaries between different vascular territories, watershed infarction, or 2. In the deepest and least well collateralized regions of a vascular territory, internal border zone infarction. In either case, the cause is usually distal hemodynamic perfusion failure related to a more proximal stenosis or occlusion. C. Lacunar infarction appears as a small, deep infarction within the territory of a single, small penetrating artery. The mechanism is usually related to occlusion within the course of the small vessel, microtheroma or lipohyalinosis. Pause the video and carefully scrutinize Figure 6.7 illustrating axial section at the level of the thalamus showing the anatomic distribution of the major cerebral vascular territories before advancing to the next slide. Pause the video and carefully scrutinize Figure 6.8 illustrating a schematic representation of different topographic patterns of cerebral infarction before advancing to the next slide. 4. Prevent neurologic deterioration related to an evolving stroke, that is the 72-hour window. Once an ischemic stroke is completed, progression occurs in 20% to 40% of hospitalized patients, with the risk highest in the first 24 hours. Clinical deterioration can result from one of 3 mechanisms. A. Extension of ischemic territory. This may result from either progressive thrombosis within an occluded vessel, e.g., progressive brainstem infarction in a patient with basilar artery thrombosis, or distal perfusion failure related to a more proximal stenosis or occlusion, e.g., enlargement of internal border zone infarction in a patient with ICA occlusion. Approach. Full anticoagulation with unfractionated heparin may be used to prevent progressive thrombosis, although there is limited evidence of its efficacy, and its use in general is not recommended. Optimization of volume status and blood pressure may be used to mitigate perfusion failure. The best results occur if the patient has a fluctuating deficit or history of crescendo transient ischemic attacks, which is suggestive of hemodynamic perfusion failure. B. Hemorrhagic conversion. This problem is frequently identified radiographically but seldom results in clinical symptoms. The three main risk factors are increased patient age, large infarction size, and acute hypertension. Risk factors for symptomatic hemorrhagic infarction include age above 75 years, NIHSS score 10, hyperglycemia, and extensive early infarction signs. Approach. Defer anticoagulation of high-risk patients. Treat severe hypertension. D. Progressive edema and infarction swelling. This problem is generally limited to large MCA and cerebellar infarcts. Brain edema generally peaks 3 to 5 days after onset and is rarely a problem within the first 24 hours. Approach. Treatment with mannitol or hypertonic saline may be beneficial. See Chapter 13. Avoid hypertonic fluids. Steroids are not effective. For patients with significant neurologic worsening, lethargy, pupillary signs, or ipsilateral motor signs, surgical decompression is indicated. Decompressive hemicraniectomy increases survival in patients below 60 years with malignant MCA syndrome from approximately 25% to 75%, corresponding to a number needed to treat of just 2 to save a life. Patients aged 60 to 75 also benefit, but the reduction in mortality is somewhat less and there is a relative increase in disability among surgically treated survivors. 5. Prevent early recurrent stroke. That is the 30-day window. Approximately 5% of patients hospitalized for ischemic stroke experience a second stroke within 30 days. This risk is highest, greater than 10%, in patients with severe carotid stenosis and cardioembolism and lowest, that is 1%, in patients with lacunar infarction. Approach. Early treatment, i.e., within the first 30 days, with anticoagulation may reduce the risk of early recurrent stroke in patients with cardioembolism or large artery stenosis, but has not been proven to do so. Carotid endarterectomy or stenting reduces the risk of recurrent stroke in patients presenting with symptomatic high-grade stenosis. Double antiplatelet therapy with aspirin and clopidogrel can reduce the 90-day risk of recurrent stroke to a modest degree in selected patients with stuttering lacunar syndromes. We will now progress to secondary prevention and hospital management of ischemic stroke. 1. Anticoagulation. Although the use of IV heparin, start at 800 units per hour, 20,000 units in 500 ml normal saline at 20 ml per hour, for acute ischemic stroke is not generally recommended. It may be a reasonable treatment option to prevent progression or recurrence of stroke in the following situations. A. Stroke in evolution. B. High-grade large vessel atherostenosis. C. Cardioembolic stroke. D. Arterial dissection. E. Crescendo transient ischemic attacks. And F. Dural sinus thrombosis. Keep in mind that heparin is relatively contraindicated in patients with large infarcts associated with mass effect or hemorrhagic conversion. 2. Antiplatelet therapy. Give aspirin 81 to 325 mg orally daily within 48 hours of onset. Aspirin is associated with a very small reduction in mortality and the risk of recurrent ischemic stroke in the first year. In patients with progressive or fluctuating small vessel ischemia, capsular warning syndrome, and a NIHSS score 3, the addition of clopidogrel 300 mg on day 1, followed by 75 mg daily for 21 days, is associated with a 3.5% absolute reduction in recurrent stroke at 90 days compared to aspirin alone. 3. Perform cardiac rhythm monitoring in all patients on admission for a minimum of 24 to 72 hours to possible paroxysmal atrial fibrillation. 4. Consider intensive care unit (ICU) observation in patients with clinical or radiographic signs of massive hemispheric or cerebellar infarction, depressed level of consciousness, respiratory distress, or fluctuating deficits or stroke in evolution. 5. In selected cases with a fluctuating deficit and documented large vessel stenosis or occlusion, a 30-minute trial of induced hypertension with phenylephrine 2 to 10 mg per kilogram per minute targeted to raise the systolic blood pressure by 20% can lead to immediate improvement of the neurologic deficit in approximately 1/3 of cases. If no improvement is observed after 30 minutes, the infusion should be stopped. Close clinical monitoring of cardiac rhythm and blood pressure is essential. 6. Obtain a neurosurgical evaluation for possible decompressive surgery in patients with large cerebellar infarction or complete MCA territory infarction with midline shift and deteriorating level of consciousness. 7. Consider MRI including diffusion-weighted imaging in patients with posterior circulation strokes, or if the infarction is not well delineated by CT. 8. Order a non-invasive neurovascular workup. Proper decisions regarding the treatment of cerebral infarction are based on elucidation of the mechanism of the stroke. The following tests should be performed in every patient. A. Echocardiography is an important technique for identifying cardiac sources of emboli. In many patients, transthoracic echocardiography is adequate. Transesophageal echocardiography provides more detailed views of the left atrium and aortic arch and is a more sensitive test for detecting mural thrombi and valvular vegetations. An agitated saline study, bubble study, is highly sensitive for detecting right to left atrial shunts, which are consistent with a patent foramen ovale. B. Carotid Doppler ultrasonography, MRA, or CT angiography is needed to rule out carotid stenosis that is symptomatic and greater than 70%, which is an indication for carotid endarterectomy. The following tests should be performed in selected patients. Transcranial Doppler ultrasonography can be used to diagnose occlusion or stenosis of the major intracranial arteries. Abnormal intracranial waveforms and collateral flow patterns can also be used to determine whether a stenosis found in the neck is hemodynamically significant. MR or CT angiography can be used to diagnose extracranial or intracranial stenosis or occlusion. Ambulatory electrocardiogram, ECG, monitoring may be useful for detecting paroxysmal atrial fibrillation in patients with a diagnosis of cryptogenic stroke at discharge, including ESUS. This form of monitoring detects intermittent atrial fibrillation in approximately 15% of patients. 9. Consider blood testing to identify unusual causes of stroke, particularly in young patients. A. Blood cultures if endocarditis is suspected. B. Procoagulant workup, protein C activity, protein S activity, antithrombin 3 activity, lupus anticoagulant, anticardiolipin antibodies, factor V Leiden mutation, prothrombin gene mutation. Note: these tests should be obtained before anticoagulation is started. See vasculitis workup. Anti-nuclear antibody, abbreviated as ANA, rheumatoid factor, abbreviated as RF, rapid plasma Reagan, abbreviated as RPR, hepatitis virus serologies, erythrocyte sedimentation rate, abbreviated as ESR, serum protein electrophoresis, abbreviated as SPEP, cryoglobulins, and herpes simplex virus, abbreviated as HSV, serologies. D. Coagulation profile to rule out disseminated intravascular coagulation, abbreviated as DIC, E-beta human chorionic gonadotropin, abbreviated as beta-HCG. Testing to rule out pregnancy in young women with stroke. Refer to Chapter 24 for further discussion of specific ischemic stroke syndromes, evaluation of transient ischemic attacks, and the secondary prevention of ischemic stroke. We will now discuss management 2. General care. Much of the morbidity and mortality associated with stroke is related to non-neurologic complications, which can be minimized by adherence to these guidelines. 1. Fever. Fever exacerbates ischemic brain injury and should be treated aggressively with antipyretics, acetaminophen, or a cooling blanket, if necessary. 2. Nutrition. Stroke patients are at high risk for aspiration. Patients with depressed level of consciousness, brainstem strokes, bilateral strokes, and large hemispheric strokes carry the highest risk. Formal assessment of swallowing ability by a speech pathologist should be completed before patients at risk are fed. Start enteral feeding via a nasoduodenal tube within 24 hours after the stroke if the patient cannot swallow safely. 3. IV hydration. Hypovolemia is common among stroke patients and should be corrected with isotonic crystalloid. Avoiding volume depletion may be particularly important in patients with intracardiac thrombi. Dehydration has been linked to progressive thrombus formation, or hemodynamic stroke. Hypertonic fluids, e.g., D5W and 0.45% saline, can aggravate cerebral edema and should be avoided. 4. Glucose. Hyperglycemia and hypoglycemia can lead to exacerbation of ischemic injury. In critically ill stroke patients, it seems prudent to prevent hyperglycemia, glucose level higher than 180 mg per deciliter, with intensive insulin infusion, 0.5 to 1 unit per hour to maintain glucose levels between 120 and 180 mg per deciliter. 5. Regarding pulmonary care, chest physical therapy, every 4 hours, should be ordered to prevent atelectasis in immobilized patients. 6. Regarding head of bed elevation, elevate the head of bed 30 degrees to reduce the risk of ventilator-associated pneumonia, improve orientation, and minimize intracranial pressure. 7. Regarding activity, patients with stroke should be mobilized and engaged in physical therapy as soon as possible after the first 24 hours. For immobilized patients, order patient turning every 2 hours, to prevent pressure sores, and joint range of motion exercises 4 times a day to prevent contractures. Heel splints to maintain the ankle in dorsiflexion can also prevent shortening of the Achilles tendon. Have the patient taken out of bed to a chair every day as soon as feasible. 8. Regarding prophylaxis for deep vein thrombosis, abbreviated as DVT, ischemic stroke patients with significant immobility who are not on IV heparin should be treated with enoxaparin 40 mg once daily or heparin 5,000 units every 12 hours to prevent formation of deep vein thrombosis. This treatment can be started safely in patients with intracerebral hemorrhage after 24 hours. 9. Regarding bladder care, indwelling urinary catheters should be used judiciously. Order intermittent catheterization every 6 hours when possible. Thank you.